Ik denk dat je niet zo vreselijk veel macht hebt om dingen anders te laten gaan. Het gebeurt gewoon.
Maar ja, ik ben wel blij dat ik gewoon nog leef natuurlijk.
On voit l'être aimé, complètement distordu et il est là, il est plus là, mais en même temps il est là.
Quando hai alle spalle un dolore, una sofferenza del genere, apprezzi anche le piccole cose. Non è scontato niente, non è scontato che respiri, non è scontato che stai in piedi e cammini, puoi correre, non è scontato vedere il sole, non è scontato niente.
Bijna verdwaasd rond, in een trance rond. Maar ik moet zeggen, de zorg eromheen is wel heel erg goed. En ja, het was een heftige tijd, maar wel een mooie tijd.
Welke gevoelens ik heb ervaren. Ja, je bent ontzettend nauw betrokken bij mijn vrouw, wat die meemaakt. En je kunt daar niks mee, maar je moet er zelf mee uit de voeten. En je hebt wel het volle vertrouwen, dat had ik wel steeds.
Io sono un medico di terapia intensiva, non un rianimatore, nel senso che lavoro con i neonati, quindi mi occupo di tutt'altra, di bambini molto molto piccoli, non faccio il loro stesso lavoro, però chiaramente il rapporto con i medici è stato condizionato anche dalla mia posizione, tra l'altro sono dei colleghi perché sono nel mio stesso, quindi da una parte ero sicuramente facilitata nel comprendere razionalmente quello che stava succedendo, cioè non avevo bisogno dei lunghissimi colloqui perché mi spiegassero per avere notizie cliniche, perché era più semplice riassumermi le cose. D'altra parte, dal punto di vista umano, dal punto di vista emotivo, questo non è servito a niente, anzi forse ha peggiorato le cose, perché sapevo cosa poteva succedere e non volevo accettarlo.
Ahora lo que me motiva es mejorar la vida de la gente. Ya no es tanto la técnica, ¿no?, como cuando eres joven, porque llega un punto que la técnica es técnica y no tiene ningún secreto, sino las pequeñas cosas que pueden hacer que marcan la diferencia. El hablar con el paciente, con la familia, el hacer una educación sanitaria que nadie ha hecho hasta ese punto y tú no lo sabías porque dabas por hecho que lo habían hecho. Esas cosas son las que te motivan, el mejorar el cuidado del paciente.
Il faut faire du cas par cas, en fait. C'est primordial, parce que chaque histoire est différente. Et quand vous vous trouvez en tant que patient, en tant que famille de patients, dans cette situation, dans un univers où vous ne parlez pas cette langue-là, cette langue faite d'acronymes et de termes techniques que vous ne connaissez pas, quand vous vous retrouvez face au savoir et que du coup vous vous retrouvez impuissant, que vous vous retrouvez stupide, que vous vous retrouvez humilié, que vous vous retrouvez démuni, comment faire ?
Jokainen lääkäri varmaan pelkää komplikaatiota tai jotakin, että mitään ei hiffaa jotain juttua, mitä olisi pitänyt hiffata, joskin siinäkin auttaa se, että harvoin tekee yksin koko päivää töitä. Nämä tuli nyt äkkiseltään mulle mieleen.
And what scares me is that making those decisions and making those wrong decisions and the realization that that decision in 3-4 weeks' time, where you end up having a patient who, in effect, can be crippled by life-sustaining therapy, which may not have been in their best interests or the family's best interests. And that still scares me. And I think it scares a lot of colleagues, but intensive care is much more multidisciplinary now, and I think that has helped our decision-making and has reduced that fear factor.
Honesty and humility go a long way. And most patients and relatives understand that we're also human and mistakes can happen and should be openly discussed.
Οι ασθενείς όμως έρχονται σε επαφή με εμάς, ιδιαίτερα αυτοί που βγαίνουν από το νοσοκομείο, πηγαίνουν σε κέντρα αποκατάστασης και ύστερα από πάρα πολύ καιρό έρχονται να μας συναντήσουν, γιατί ξέρουν τα πρόσωπά μας, τις φωνές μας, τον αγώνα που δίνουμε μέσα στο χώρο για να καταφέρουμε να τους σώσουμε, να επιβιώσουν και έρχονται να μας δουν, να μας γνωρίσουν από κοντά, να τους δούμε κι εμείς.
Together with my colleagues, in particular the nursing colleagues, we arranged a wedding for a patient who was at the end of his life and had decided to marry his long-term partner before he later died. And it was very moving to be part of this very special event in the intensive care unit.
It's a real privilege to be able to support a patient and their family through that, what I hope is the worst thing that ever happens to them in their lives, to be able to support them through that, hopefully to recovery, or to support them through managing a dignified death.
Il faut ramener la vie. Pourquoi est-ce que tout est si blanc et voire gris? Pourquoi est-ce que ce lino couine autant sous les crocs des médecins? C'est insoutenable. Pourquoi est-ce que tout est autant aseptisé? C'est pas 3 photos qui vont empêcher les gens de travailler. Moi, je pense que c'est important de ramener de la vie à cet endroit où on se trouve à la frontière au bord d'eux, on se trouve dans une espèce de no man's land où on sait pas sur quoi ça va déboucher, quoi.
La mia opinione della terapia intensiva è fantastica perché mi hanno salvato la vita e dopo 3 anni sono qui. Anche a un altro ospedale che mi hanno dato per morto, per fortuna sono arrivato a questa terapia intensiva e mi hanno salvato veramente la vita.
Solo belle cose possono uscire dalla mia bocca, ovviamente, perché senza di loro non sarei qui, ripeto, non sarei qui oggi.
Intensive care medicine allows me to learn something new every day. So every day I meet colleagues and I hear of their new technologies, new advances, and progress in their particular specialty. But most importantly, every day is a different day with new challenges, and I enjoy the interaction with my colleagues and most importantly with patients and their relatives. So it provides a great variety, it's different every day, and it's a specialty where progress is made on a regular basis.
Grazie perché mi hanno ricordato anche come si lavora. Cioè, io faccio questo mestiere, lo faccio da tanti anni, ci sono dei momenti in cui sei stanco, in cui hai le tue cose, nel senso che hai la tua vita, hai delle preoccupazioni, però io ero serena quando andavo via, non perché sapevo che non sarebbe morto, poteva morire, poteva star male, ma era nelle mani migliori. Sapevo che era nelle migliori mani e questo mi dava quel minimo di tranquillità che potevo cercare. È giusto che i bambini che mi vengono affidati e i genitori quando vanno a casa possano pensare la stessa cosa. Siamo nelle migliori mani, quindi dobbiamo sempre fare il meglio. Grazie a loro per esserlo il meglio.
I'm an intensive care nurse, and I'm proud to work with a multidisciplinary team to work together to fight COVID-19. Together, we are intensive care medicine.
I'm an anaesthetist, and I'm proud to be an intensivist. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
I'm a primary intensivist, and I'm proud of it. We intensivists are working together side by side to fight COVID-19. Together, we are intensive care medicine.
I am an anesthesiologist, and I'm proud to be an intensivist. We intensivists working together to fight the COVID-19. Together, we are intensive care medicine.
I am a surgeon, and I'm proud to be an intensivist as well. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
Good afternoon, good morning, good evening, wherever you are in the world, and welcome to our symposium looking at optimizing ventilation and oxygenation to protect vital organs in COPD in hypercapnic patients. I'm Basil Matta. I'm one of the consultant intensivists at Cambridge University Hospital, a part-time senior medical director for Massimo, and I'm joined by my colleague, Chiara Robba, who is a consultant in anesthesia and intensive care in Genoa in Italy. This afternoon, we have 3 speakers for you. They'll all be speaking about 15 minutes each, and we will have a chance to have a question and answer session at the end. Please send your questions online, and I will allow Chiara now to introduce the first speaker.
Thank you, Dr. Matta. Thank you to ESIC for organizing this interesting symposium, and to Massimo. I will just introduce you briefly the first speaker. His name is Professor Sigismond Lasowski. He's the head of anesthesiology and critical care department at the University Hospital of Angers in France. And the title of his talk is going to be Monitoring the Oxygen Reserve to Avoid Hyperoxemia. Hello, Professor Lasowski. Please, you can start your talk.
It's a great pleasure for me to have the possibility to talk about hyperoxemia in the ICU. I don't know if you see my slides. Hello? Do you see my slides?
Yes.
Okay. So, monitoring the oxygen reserve to avoid hyperoxia, this is the title of the speak now. These are my conflicts of interest. And first of all, I want to talk about oxygen. We all know that oxygen is a good thing, but sometimes too much oxygen is not a so good thing. In the COPD patients, oxygen is of course needed, notably in case of breathless patients. And in this meta-analysis, including 33 studies and 900 patients, it is shown that breathlessness is improved by oxygen in the COPD patients. And of course, when you give oxygen in presence, in case of exercise, it also improves breathlessness of the COPD patients. This meta-analysis shows that the PaO2 is associated with the impaired cognitive function. So the lower the PaO2, the lowest the cognitive functions in COPD patients. And this is the result of this meta-analysis, including 9 studies and exploring more than 740 patients. On the other side, hyperoxia may be deleterious too. In this cohort study, including more than 14,000 patients in 3 ICU in the Netherlands, with both surgical and medical ICU patients, it is shown that the PaO2 is associated with highest mortality when PaO2 is too low, and when you have PaO2 below 60, you have an increase in hospital mortality. But on the other side, you also have an increase in mortality when PaO2 exceeds 100 or 120 millimeter of mercury, and this analysis was adjusted on severity of the patients. In this meta-analysis published in The Lancet in 2018, including 25 randomized controlled trials and more than 16,000 patients, the authors look at RCT comparing conservative to liberal oxygen therapy protocol and they show that when you use conservative oxygen therapy, you improved survival compared to liberal oxygen therapy. And when you look at the different type of patients, it is true for all kinds of patients, for neurological ones, septic ones, emergency surgery ones, critical care ones, and cardiac patients. In all those patients, you have an increase in hospital mortality, an increase in 30-day mortality, and an increase in long-term mortality by 10 to 20% when you use liberal oxygen compared to conservative oxygen. Those data made these experts do some recommendations about oxygen therapy in the acutely ill medical patients. In these practical guidelines, they recommend to not to give oxygen when SpO2 is higher than 96%, and not to start oxygen when to stop oxygen, sorry, when it is higher than 96%, and not to start oxygen when SpO2 is below 93%. So their target an SpO2 between 90 and 92%. Taking the literature and looking at that, with their recommended target to not to stop oxygen when SpO2 is higher than 97%, and not to give it when it's below 93%, they expect to save between 11 and 51 lives per 1,000 of people treated. But on the other hand, it may be not so easy and secure to target so low SpO2. You may, when you target too low SpO2, have episodes of hypoxemia, which is bad for the patients. Indeed, in this study, before-after study, comparing standard of care to oxygenated therapy given according to those guidelines, that mean with targeting an SpO2 between 90 and 92%, you see here that the authors were able to decrease the SpO2, to decrease the mean FeO2 during the hospital stay, the ICU stay, and to have lower PaO2 in the conservative group compared to the control group. So it is possible to reduce FeO2 and thus to decrease PaO2 and to decrease hyperoxia. But when you target a lower SpO2, first of all, you were only very few time in the target, with only 3% of the time in the SpO2 targets, and you decrease the time with high SpO2, but you not avoid it completely. On the other hand, when you use conventional oxygen therapy, you may have 60% of the time with hyperoxia, but you have no time with hypoxemia, or virtually no time with hypoxemia. On the other hand, when you use a conservative oxygen therapy based on targeting low SpO2, you have always 13% of the time with hyperoxia, but you have almost 20% of the time with hypoxemia. Thus, targeting low SpO2 exposes to hypoxemia, as well as when you target low glycemia, you are exposed to hypoglycemia. And in addition, when you use SpO2 to decrease FeO2, nurses are sometimes reluctant to decrease FeO2 when SpO2 is in the normal range. Indeed, in this study, in 88% of the time, FeO2 was not decreased when FeO2 was between 1.3 and 1.4, despite high SpO2 levels. So targeting low SpO2 to prevent hyperoxia has drawbacks. First of all, FeO2 are not decreased for usual FeO2 or SpO2 values. And secondary, it exposes to more hypoxemia. This is why we conduct this randomized control study to evaluate the interest of the oxygen reserve index monitoring. Our hypothesis was that oxygen reserve index may help detecting hyperoxia. Indeed, as you see in the left panel, the SpO2 increases when PO2 increases 0.8 millimeter of mercury. That means just to normoxia. But when you have a PO2 higher than 100, that means when you have hyperoxia, then SpO2 is asymptotic to 100%, and you are not able to detect hyperoxia. The oxygen reserve index is an index that rises from 0 to 1 when PO2 rises from 100 to 200. So it could be able to detect moderate hyperoxia where SpO2 is always 100 or more. So our randomized control study included adult critically ill patients ventilated for an expected duration of more than 48 hours. The inclusion will should take in the 6 hours following intubation. In the intervention group, the ORI group, oxygen rate was decreased by nurses when ORI was greater than 0. And in the control group, oxygen rate was decreased by nurses when SpO2 was higher than the prescribed upper limits of the SpO2. The outcome was the percentage of days with hyperoxemia defined as a PO2 higher than 100 millimeter of mercury. Randomization was stratified on inclusion PF ratio, and a follow-up was till day 28 or ICU discharge. That means that oxygenotherapy without mechanical ventilation was also explored. So after inclusion, patients were randomized to have the root monitor switch off, so they all have the rainbow sensor to detect SpO2. In this control group, the FeO2 was decreased when the SpO2 was greater than the upper limit. The upper limit was prescribed according to the type of patients, 95% for COPD or ARDS patients, and 99% for the other patients, including brain injured patients. And the FeO2 was increased when the SpO2 was lower than 90, 92, or 95%, depending on the patients. In the intervention group, the ORI group, the FeO2 was decreased when ORI was greater than 0, and the FeO2 was increased in the same cases as in the control group. The outcome was the percentage of days with a PO2 higher than 100 till day 28 or ICU discharge. Here is the flow chart of the patients. So we randomized 150 patients and included 75 in the OA group and 71 in the control group. There was no difference in baseline characteristics for the two groups. However, the shock was more frequent in the OA group than in the control group. We had around 9% of the patients with COPD. Here are the main results. So we observed a reduction of more than 50% of hyperoxia duration, either as the number of days with hyperoxia, the number of hours with PO2 greater than 100 or greater than 120 millimeter of mercury. And very importantly, we have no difference in the number of days or the duration of hypoxemia. So we were able to reduce the hyperoxia without increasing the hypoxemia. So to conclude, the oxygen reserve index allows a reduction of the time spent with hyperoxemia without increasing the hypoxemia time, which is not the case when you use SpO2 to lower the hyperoxemia. It's easier to implement than SpO2 because nurses are reluctant to decrease SpO2 when SpO2 is normal, but they may easily decrease SpO2 when the ORI, which is a new index, is not normal, which could be higher than 0. And then we need more patients to assess the clinical outcomes using oxygen reserve index. Thank you.
Thank you very much, Professor Lesowski. Very, very interesting talk. Let's see if we have any questions.
Questions at the end, I think. Chiara.
Okay.
Right.
Okay, thank you again. Now we move on to the next speaker. The next speaker is Professor Rafael Badenes. He's from the Department of Anesthesiology and Surgical Trauma Intensive Care, and he's full professor at the University of Valencia. The title of his talk is going to be Making Sure the Brain and Vital Organs Are Well Oxygenated, Cerebral Oxygenation. So thank you very much, Rafael, for being with us, and it's your turn.
Hello. Thank you so much, Chiara. Thank you so much, Basil, for your nice introduction. And thank you so much, SACM, for giving me this chance to share information. So I am very proud to be here. So as you mentioned it, we will talk about making sure the brain and vital organs are well oxygenated, talking about cerebral oxygenation. My name is Rafa Badenes from Valencia. So let's see. I would like to start my first slide, my presentation with this is sadly remembered because we will focus on COVID-19, we will focus on COPD patients, and we will focus on the brain oxygenation. So my first slide is just sadly remembered to the total confirmed COVID-19 deaths. We are more than 500,000 of deaths, so that's terrible. But on the other hand, we will feel so proud to be in the front line. So it's an honor for us to be fighting with this devastating pandemic. So as we will talk about monitoring, I would like to remember this is a very nice book that all of you know, that is The House of God. And this is the 10 commandments. And then at the number 10, you can see if you don't take a temperature, you cannot find a fever. That's the important point. So let's see. I would like to start with this. This is an outstanding clinical update from John Marini and Luciano Gattinoni talking about the management of COVID-19 respiratory distress. You can read it. It's very famous. But I don't fully agree with caution. I don't fully agree, for example, with some sentence like this one. Early intubation, effective sedation, and/or paralysis might interrupt this cycle. So I am more agreed, like opinions like my colleague Wes Ellie, that it's not only lungs being harmed in this pandemic. So sometimes we stop the Billy Vortex via calming clonidine or Dexmed or Aldol. In this way, I would like to share with you this very recent review from Martin Tobin about the caution about early intubation and mechanical ventilation in COVID-19 patients. So let's see about this. It's published very recently in Annals of Intensive Care. And this is some experts have argued that mechanical ventilation should be employed early in order to prevent COVID-19 patients progressing from mild disease to more severe lung injury. And talk about the patient's self-induced lung injury called PCLI. Okay, so this is Martin Tobin, this claim because say, okay, Gattinoni and co-authors advocate radical change to ventilator management of patients with COVID-19, and they claim that non-invasive options are questionable value, and intubation should be prioritized. So I agree, but partially, because I don't fully agree with this sentence. So because I think that there is no justification for liberal use of endotracheal intubation at early steps. And let's move with this situation, that early intubation, non-invasive, or delay intubation. Let's move to this very, very nice paper published very recently in Lancet Respiratory Medicine 2 weeks ago. And this is from the group of Luciano Gattinoni. And the key point, in my point of view, is when to move from high-flow nasal cannula of non-invasive ventilation to move to invasive ventilation. This is my key point. And I must first, the speaker said sometimes it's not only talking about peripheral saturation, and sometimes it's not only about PaO2. So perhaps we need more data to move from non-invasive to move from high-flow nasal cannula to invasive ventilation, because all of you know that sometimes the combination of non-invasive ventilation and prone position is a good way to treat these patients. So let's see about it. In this scenario, let's move to COPD, the chronic obstructive pulmonary disease. This is published in Journal of Thoracic Disease. This is like a clinical characteristics of COVID-19 infection on COPD patients. There are around 1,000 patients. 1,000 about patients without COPD and 50 patients with COPD. So obviously, if this is the complications, treatments, and clinical outcomes, obviously, you in the group of COPD versus the group of non-COPD, you can observe that you need in the COPD more oxygen therapy, more mechanical ventilation, low invasive and non-invasive. So that's it seems reasonable. It makes sense. But as you know, if you are COPD with COVID-19, you are in troubles, because this is the cumulative survival probability obviously is lower if you are COPD patients. So that's it seems reasonable. So they suggested then the importance of early detection, isolation and treatments, and multidisciplinary intervention for patients with COPD and COVID-19. Okay, and what about the clinical features of COVID-19? This is a nationwide study in China. This is an EPUB ahead of print in Critical Care Medicine the last week, talking about the clinical features. And let's see about this. So this is the variables related to bad outcome. So you can see, for example, the hazard ratio of ventilation, invasive versus not invasive, are related to a hazard ratio near of 3. All of we know of this. This is the creatinine. This is the COPD. It's related, the 4.557. It's related to bad outcomes if you are not COPD patients. So the combination of COPD and invasive ventilation that sometimes we need it's a bad combination because it's related to bad outcome. So you can see the CAM survival, obviously, all we know, if you apply invasive ventilation, obviously the patient are sick and more illness. So if you apply invasive ventilation versus non-invasive, the outcome it's lower and it's bad. And in the same is the COPD. But the important message for me of this important paper is, if you have in the table 1, this is the variables associated with invasive mechanical ventilation requirement in ventilated COVID-19 patients. And you can see that the sex, the age, the D-dimer, the prothrombin time, and the C-reactive protein. There is not COPD related to the use of invasive mechanical ventilation in COVID-19 patients. So have a look that if you are COPD, you are in problems. If you use invasive mechanical ventilation, sometimes you need to use it, obviously, but you need to think about non-invasive or high-flow nasal cannula in this patient. Let's move to the algorithm of the management of patients with acute hypoxemic respiratory failure secondary to COVID-19. And you can see, for example, imagine that target peripheral saturation about, as my first speaker said, 92 to 96. But it is coffee for all. Why 92? Then when 92 move from non-invasive to invasive, or what do you manage this situation? Or it's 96, or let's move to the PaO2, or there are some tricky questions because the range, you need to know the range because sometimes it's difficult to know how to move from non-invasive to invasive mechanical ventilation. In the same way, this is a graphical from Belli Antonini. So it's the same way. What about you are below 92 or 90, or from 90 to 96? Where you have, in my point of view, a very high range to apply, so sometimes it's difficult. But which is the end point of your peripheral saturation? Which is the end point of your systemic oxygenation? That's focused on the brain injury, really, that the Chiara paper. So after all, brain oxygenation is what really matters. So you are worried because about the brain oxygenation as a primary end point of your systemic oxygenation. So perhaps you can titrate your respiratory management depends on the brain monitoring. So we can monitoring as a non-invasive the brain oxygenation. Yes, we can. This is a paper for us, and you can monitoring invasive and non-invasive as a regional brain oxygen saturation. We call NIRS, near infrared spectroscopy, and you can measure what is the relation about brain oxygenation. What are we really measuring? Sometimes it's an important question. What are we really measuring with brain regional oxygen saturation? This is an excellent paper from a Polish group. I fully recommend it to read it. What are really measuring, which is what we suppose, or something like that. But very easy, very pragmatical approach. The difference between peripheral saturation and the value of your brain regional oxygen saturation is the oxygen extraction fraction. So if your value, you have for example, 100% of peripheral saturation, and you decrease your value of your brain regional oxygen saturation, it's that the oxygen extraction fraction is higher. So it's the relation between the peripheral saturation and the brain regional oxygen saturation, the oxygen extraction fraction. And this is important. For me, yes, we have some bibliography in the perioperative setting in different surgeries and non-cardiac surgery, but it's important because it's an end goal monitoring, it depends on PaO2 and also PaCO2 and obviously the hematocrit and the mean arterial pressure. So if you have a good value of the brain regional oxygen saturation, you feel very comfortable because it's related to some different variables. So that's a good point. What about, this is not published yet, this is a proposal, we are working on it, it's working with Chiara and some colleagues from Europe. This is a pragmatical approach in order to correct the cerebral desaturation. So for example, this is not published, be caution with this, NIS value reduction more than 10% bilateral or unilateral, or an initial NIS value less than 50%, just check step by step. The first step is check about the mean arterial pressure. And if you have minus than 60 millimeters of mercury, treat and find etiology. But the second one is very important for me, and more in COVID-19 patients and more in COPD COVID-19 patients, because you can titrate your PaCO2, it depends on the value of your regional brain oxygen saturation. For example, for some patients, perhaps you can be tolerated with values of 80 or 83, or perhaps in another patients, you need a PaO2 around 100% or 100 and 120%, which is some difference, the range. So treat and find etiology to titrate as a second step. The third step, very important in COPD patients, is the PaCO2, because sometimes you know that sometimes the value is higher, but you can titrate it. It depends of the value of the brain regional oxygen saturation. The fourth step is to check about the hemoglobin and use it as a trigger for transfusion. And the last one, as a systemic observer, just check the central venous oxygen saturation. This is for the availability for delivery of oxygen to the brain. Sometimes it's not a problem to the delivery of oxygen, it's a problem to the consumption. And for example, in our patients with COVID-19, sometimes the fever is a problem. So you need to assess cerebral oxygen consumption as a next step. Treat and find the etiology of temperature, think about of the seizures, and in case of the patient is in acute brain injury, sometimes it's difficult, COVID-19, COPD, and acute brain injury, but sometimes can occur. So let's check about ICP. So with this situation, okay, you say, okay, Rafa, the message is, yeah, use your brain oxygenation value to titrate the respiratory devices, to apply invasive or non-invasive. What about evidence-based medicine of this monitoring? So, but have a look at the evidence-based monitoring, evidence-based medicine of pulse oximeter for perioperative monitoring. And the pulse oximeter does not improve overall patients' outcomes and does not reduce morbidity and mortality. And all of us use, obviously, pulse oximeter for all of anesthesia, for all of ICU patients, and for all of patients that we see. So with this situation, I would like to, with this situation that we are with lights and shadows with the pandemic, obviously, you know, we are still in troubles, not as in Europe, not like 1 or 2 months ago, but we are always in trouble. We are in a situation, the lights and shadow. By my take-home message is, after all, brain oxygenation is what really matters. If you want to titrate, if you want to achieve one value of peripheral saturation of PaO2, really is to get to achieve a good value of brain oxygenation. So in this situation, this is my last slide. This is my email for questions and a slide request. And I would like to remember that we love with the brain. So I love you with B. And that's my final slides. Thank you so much for your attention.
Thank you, Rafa, for an excellent talk. Really good, really good. I'm sure we'll have some questions at the end. Our last speaker is Dr. Jens Ronlich. He's the expert pulmonologist from the University of Leipzig in Germany. He's a real expert on ventilation, and not just normal modes of ventilation, but NIV, hypercapnia, and high flow nasal oxygen. Jens, please, we look forward to your presentation.
Okay, can you hear me?
Yes.
Yes, great. Okay, thank you for the invitation. I want to speak about delivering oxygen for chronic hypercapnic COPD patients. And I have some facts, some problems, and perhaps some answers for you. First of all, we know since the latest century, long-term oxygen therapy is beneficial in COPD. You see it in this study, the report of Medical Research Council Working Party. And in this study, we have mainly patients with hypercapnia, and you see the survival curve for patients with oxygen is better than without. That's why the British guidelines recommend that you should describe LTOT for patients with resting hypercapnia if they fulfill all other criteria for LTOT, perhaps with a nasal cannula or alternative with a Venturi mask system. But especially in our patient groups, there are some problems if you are hypercapnic and you need oxygen. The first of all, we have the problem of hyperxemia. You can have high demand because of your respiratory disease in chronic hypercapnic COPD patients, but you can also have an hyperxemia which is device related. And you can see it in this benchmark study from Baxter from 2007 on the left side. Here the patients had a face mask with oxygen, and the investigators described a decrease in oxygenation in these patients if they have a higher respiratory rate. And this is a problem if a patient with COPD is on exercise or have an acute exacerbation with a higher respiratory rate. The reason for this device-related hypoxemia is additional air entrainment. If you imagine, you see on the left side a very beautiful nose from my son. You see, if you have low flow oxygen and introduce this in the nose, you have, with a normal respiratory rate, a good oxygenation. But if you have a higher respiratory rate, you have a flow up to 150 liters per minute, and then you can suction a little bit more non-oxygenated room air, and that's why you have a dilution of your inspired mix of room air and oxygen, and that's why the alveolar FeO2 decreases. This is a problem in low flow oxygen systems. Another problem, from my point of view as pulmonologist, is that after an exacerbation of COPD, 77% start oxygen long-term therapy directly after this exacerbation. And you can imagine, and these are some studies I have on this slide, these patients have a reversible hypoxemia, and up to 70% of these patients needs no oxygen in the next 3 months. That's why the British guidelines also recommend that you should have a stability of 8 weeks after the last exacerbation before you describe long-term oxygen therapy. And as a consequence of this long-term oxygen therapy, if not necessary after the time after exacerbation, you can have, and the first speaker had this also pointed out, an hypoxemia in these patients. In some patients, you can induce an hypoxemia-induced hypercapnia. So you see this on the left side. If you have a lot of oxygen in your COPD patients, your minute volume decreases and your PCO2 increases, and so you have a problem with this patient. This is not only true in stable hypercapnic patients. You can see this on the slide from François Lelouch, that the PCO2 increases with higher oxygen levels, but also in the acute setting, and this is more dangerous than in the stable condition, but a lot of patients have a lot of oxygen at home, and if they have a higher respiratory rate on exacerbation, they use a lot of oxygen, and that's why they came to the emergency room with an hypoxemia-induced hypercapnia. And you see this in these different studies on this slide. 50% of these patients have an hypoxemia at admission, and the half of them have a hypercapnia. 20% have a respiratory acidosis, and 24 patients have an hyperoxemia, and 50% of them have a respiratory acidosis because of the hypoxemia. Now, the big question is, how can we deliver oxygen in hypercapnic or pending hypercapnia COPD patients? That's the big question. And I have some answers and one new idea to do this. The recommendation in the BTS guidelines recommend clearly that you should monitor if you initiate LTOT in patients with a stable hypercapnic COPD with a monitoring of respiratory acidosis and hypercapnia, and you should use as the first choice a nasal cannula or also a venturi mask with the limitation. Another way to do this comes from this study. In this study, the patients were investigated if they can improve exercise capacity with an automated oxygen titration with a device, and you see the device can measure the SpO2 on the right side, on the upper right side, and on the right lower side, you can see the oxygen flow will get higher if the patient need a little bit more oxygen. You can also see on the slide on the left side, the walking distance in our COPD patients, there are hypercapnic in this study, is much higher than another because of the preventing of an relevant hypoxemia in these patients. And the British guidelines also recommend if you have a patient who developed a respiratory acidosis during an LTOT initiation, you should use a non-invasive ventilation to provide hypercapnia, especially in the night. And you know these studies from Patrick Murphy on the left side and from Thomas Kuhnlein on the right side, you can decrease with home oxygen in addition and with non-invasive ventilation, the hospital admission and the exacerbation rate. And on the right side, by the study from Thomas Kuhnlein, you can see the mortality in the group which was treated with non-invasive ventilation and oxygen was much lower. But this is not the best way. You have also a lot of patients who don't tolerate. In my clinical practice, is this very often a problem. You can have an intolerance in these patients. And in some study settings, you have a failure rate because of intolerance from 11 to 30%. And also in especially older patients and patients with a lot of diseases, you have an intolerance up to 34%. These are studies, yes. In the real life, there are much centers who have no experience with non-invasive ventilation and can therefore only treat these patients with oxygen. And one very good device was developed in the last years and comes from the neonatal medicine is the nasal high flow. The nasal high flow is a little bit special and more comfortable than other oxygen or non-invasive ventilation devices. It works with a room air flow rate, no oxygen. This is very often a mistake. With room air, with a flow rate from 20 to 60 or 50 liters per minute, have a high temperature, very full humidity, and you can, if you want, supplement some oxygen in these patients. And the mechanisms of action of nasal high flow therapy are very changed from some other things like non-invasive ventilation, because you have only a low increase in airway pressure that is not enough like a good CPAP or a good non-invasive ventilation with a high pressure or the high intensity non-invasive ventilation. Despite of this, it can change the breathing patterns. It can decrease hypercapnia by an airway washout and a decrease in dead space ventilation, and therefore an improvement in alveolar ventilation. And you can have a stable oxygenation in high respiratory rates on high tidal volume. And I will see you this fact on the last slides now. You know my nose. When you see on the left side what you have seen before, the low flow oxygen system with the dilution of the non-oxygenated room air. But if you have an inspiratory flow up to 150 liters per minute, and you cover this flow with a nasal high flow of 60 liters per minute, the suction of room air, non-oxygenated room air, is much lower. And that's why, as a consequence, and you know this picture, is that you have no decrease in oxygenation and higher respiratory rates. If you use nasal high flow in patients with a normal respiratory rate, you see here on the red thin line that you have no benefit from nasal high flow compared to normal oxygen masks or nasal cannulas. But if you work with this in higher respiratory rates, you have a stable oxygenation because of the no dilution, additional dilution of the inspired oxygen because of the high flow. This is also true not only for the respiratory rates, also if you have higher tidal volumes, and you can see on the left side a low flow oxygen system, and please look to the 6 liters per minute. The different bars describes different tidal volumes from 300 to 700. And on the right side, you see a nasal high flow system, also with the same tidal volumes, 300, 500, and 700. And you can see as higher your tidal volume is in these patients, the more stabilization of oxygenation you can see if you use a nasal high flow device. And that's why the oxygenation during nasal high flow is much better, but not because of the recruitment of atelectatic lung areas, because of the dilution. And we have also looked at chronic hypercapnic patients at home in this study published in 2019, and we compared 102 patients with a stable hypercapnic respiratory failure and COPD without any exacerbation in the former 6 weeks, and we randomized these patients to 6 weeks of nasal high flow use, mainly in the night, and non-invasive ventilation, very good German non-invasive ventilation with high pressure. And after 6 weeks, we make a crossover between these two groups, and then the patients also used over 6 weeks this nasal high flow or non-invasive ventilation. And what we found was a comparable, we had no non-inferiority study. We have only described this effect, a decrease in hypercapnia in this patient. You see all the patients in this waterfall plot. On the upper side, the nasal high flow, on the lower side, the non-invasive ventilation. And we found we had a good oxygenation in these patients, no hypoxemia or hyperoxemia, despite of the of more oxygenation during nasal high flow device, and a decrease in PCO2. And I think, or for my opinion, this might be a good way to give such patients, in case of intolerance of NIV or instead of non-invasive ventilation, to make it sure to deliver oxygen to patients with stable hypercapnic COPD, such a nasal high flow device. And thank you very much for your attention.
Thank you very much, Jens, for a very interesting talk. Thank all the speakers. Actually, I think we have some questions from the audience. The first question is directed at Professor Lasocki. It talks about really the benefits of ORI in this current crisis in COVID. Do you see a use for ORI in COVID patients?
Yes, I see use of for oxygen reserve index to reduce oxygen or to reduce hyperoxia. And in COVID patients, sometimes we give, for those not intubated, a lot of oxygen because they have a high respiratory rates, so we believe they are breathless, and we give maybe sometimes too much oxygen. So it may prevent to have too high PiO2 for those patients by just targeting a 0 oxygen reserve index. And then that's one point. And the other one, the oxygen reserve index has also been proposed in the operating room for intubations has an alert for the desaturation of the patients. So for those patients who are, when you have to intubate them, and when you have a pre-oxygenation, the oxygen reserve index rise up, and it decreases before the SpO2. So if you have some difficulties for intubation or you may be aware that the patients will have a desaturation in the next 30 seconds when the ORI goes below 0.15. That's one paper that showed that in the pediatric patients, but it's the same in the adult patients. So it is also useful for preventing hypoxemia when you intubated the patients with some difficulties. So for pre-oxygenation of the patients before intubation.
Thank you. Especially
so
with
in both hands.
Oxygenation, I suppose, really. You try not to ventilate them at the same time when they become apneic.
Yeah. Yes.
Okay. Chiara, have you got some questions there?
Yes, there are some questions. Actually, still another one for Professor Lasocki. You talked about hyperoxemia, and we all know that we need to be careful not just about hypo, but also about hyperoxemia. The problem is the threshold. What do you think about the right threshold, where to start to be worried about? Because literature is not convincing regarding one unique threshold, and maybe there are differences between different group of patients. I don't know, cardiac arrest patients or brain-injured patients?
Yeah.
Can you give us some suggestions?
So probably it's more important to avoid hyperoxemia in the cardiac arrest patients. In this population, in the New England paper, this is those patients who benefit the most of lower PaO2 or not too high PaO2. And then the question is, what is the highest tolerable PaO2? So maybe it's somewhere between 100 and 120. So I believe that especially for cardiac arrest patients, you really have to prevent high PaO2, higher than 100. And maybe for the other ones, you may tolerate some more hyperoxemia.
Thank you. Thank you very much.
Jens, I wonder if I could ask you a question, some of the things that's coming through. We've learned a lot about COVID in the last 3 or 4 months. We know it's not a straightforward ARDS as we originally everybody considered. And if we were to have our time again, we probably would do things differently. And one of the things is, I think Raphael talked about is early intubation. Where do you think, if there was to be a second wave, I hope there isn't a second wave, where would you see the role of non-invasive ventilation and high-flow nasal oxygen in terms of treating those patients rather than jumping straight into intubating them early?
Hey, thank you so much for this question. I fully agree that in this potential second wave, we will use more non-invasive ventilation. So because I think it's my personal opinion that I was wrong when my patients, 90% of my patients are under deep sedation, early intubation, tons of days, tons of sedation. So I'm very worried about this management. And we can see that with the use of non-invasive and even to combine to prone position, that it's so tolerated for the patients, it's a good approach in order to avoid or in order to reduce the incidence of intubation. So in the second wave, I guess we will use a more non-invasive ventilation like in general ICU patients.
Jens, what do you think?
Sorry?
Yes, I think also the beneficial effects of nasal high flow and non-invasive ventilation are very good in this situation. But I heard a lot of danger from aerosols. I think that's why we haven't used non-invasive ventilation and nasal high flow, and that's why we have no experience in this way. In my opinion, from a more physiological point of view, I think also we can prevent the intubation in COVID patients because of the experience with nasal high flow, especially they have no uncalculatable tidal volumes like non-invasive ventilation. That's why I think in moderate cases it could be beneficial. But today we have only some cases, but no data because of the aerosol problem.
I also believe that high flow, in fact, reduces the risk of aerosolization because the high flow prevents from aerosolization. You have some data for that compared to nasal oxygen or, for example.
Okay. I suppose we are a little bit further on now. We've got more PPE. We know the risk of infection. So we're a bit more prepared than starting to put 50, 60 liters up people's noses when we know they were infected with a bug or a virus that we didn't understand. So we may be in a different position now than we were 3 or 4 months ago. So maybe we're a little bit more prepared. One of the questions that came up actually, Rafa, was about the presentation is that if you're in a mixed ICU, it's all right for neurointensivists and neuroanesthesiologists who are used to measuring brains. If you're in a mixed ICU, what would you use to measure brain oxygenation or brain function?
Yeah, the first point is it's very difficult to speak about brain oxygenation when the moderators are the masters of the brain oxygenation. So it's very difficult to speak about brain oxygenation. Not really. Thanks for the questions. But in a mixed ICU, I will use not only to titrate the respiratory management, even to titrate the mean arterial pressure in a sedated patients. So that's the algorithm that we can to use like to titrate, because in a sedate patients for autoregulation or wherever you want, but it's as an endpoint monitoring. You can just to titrate the mean arterial pressure, you can just titrate the respiratory, the PaCO2, the PaO2, and even as a trigger, a transfusional trigger. That's the reason of this pragmatical and basic approach to the use of the brain regional oxygen saturation.
Chiara, what do you think?
Well, especially because we were talking about COVID, there are a lot of evidence, well, some evidence that probably the neurological effects of COVID are strongly related not only to a possible neurotropic effect of the virus on the brain, but also to a chronic hypoxemia. These are the results from the autopsies. So again, stay on this topic. Would you recommend, or maybe you did it already in the first wave, but would you recommend in the eventual second wave to initially monitor the cerebral oxygenation and to target our respiratory management not only on the lung but also on the brain?
Fully recommended, in my point of view, because even if you use not only as I mentioned it, fully recommended for different treatments, for to titrate as an endpoint monitoring, fully recommended.
I suppose really, as you were saying, it's a balance between oxygen delivery and consumption. So if we can't improve delivery, then we have to reduce consumption, and that's by adequate sedation, making sure they don't have a pyrexia, making sure that the CO2 is not too low or too high, and making sure that they're not seizing. So I suppose some monitor would benefit that. Yeah.
That's it.
Jens, one of the questions that's come through as well, there's a high incidence of obstructive sleep apnea in patients coming for major surgery that is undetected in the general population. Do you think those patients have got a greater risk when they have major surgery and they're not monitored post-operatively?
I haven't understand correctly the last part of your question.
There's a large population of patients who come in for major surgery who've got sleep disturbances and obstructive sleep apnea. Do you think there's a role for maybe high flow or some form of monitoring post-operatively to prevent complications in those patients?
Yes, there are one study from a French group about patients after major surgery. There were also patients with a severe obese. On the other hand, there is a problem to treat patients with a sleep apnea. There was only one study several years ago and just published, and they had only in patients with a moderate sleep apnea successful treated 16%. And this is the problem of the low pressure of the nasal high flow device. That's why in some patients it might be beneficial after major surgery, something else, but not for all. I think especially patients with sleep apnea should not be treated with nasal high flow.
Okay, thank you. Any other questions? We have one persistent question keeps saying, can you please name your cerebral oximeter? What would you use? What parameter would you look at when you're measuring cerebral oxygenation? Rafa?
What sorry?
The audience wants to know what parameter you measure when you measure cerebral oxygenation. I presume oxygen saturation, brain saturation.
Yeah. What does it mean, or what does it represent, or what is the question?
The question is, what are you measuring when you talk about brain oxygenation? What are you measuring?
Yeah, we are measuring oxygen extraction fraction, which is the difference between peripheral oxygen saturation and the value of the brain regional oxygen saturation. The difference between these two values are the oxygen extraction fraction. We are measuring always oxygen extraction fraction, who the problem could be with the delivery of the oxygen and the excess of consumption. But you know that we are measuring oxygen extraction fraction.
Yeah, so the stickers we put on the forehead, whether it's O3 or involves or whatever, measure the balance between the oxygen delivery and oxygen consumption.
That's it.
Okay. I think we're running out of time. I don't know if Chiara would like to summarize our symposium from the three speakers.
Yes, Basil. First of all, I would like to thank again the organizers, you, Basil Matta, ESIC, Massimo, etc. Here there are still questions asking which are the monitoring that you are guys using. So I think that the main interest regarding oxygenation, the CO2, etc., are the targets and how we can achieve these targets and how we can understand how to achieve them. And I think that the first step is always the monitoring of these patients. If we don't have a number, if we don't have a monitoring, we don't know where we are and where we are going. Then afterwards we can start the treatment. Basil, I would like to thank all of you. The speakers have been great. Would you like to add anything?
I think the message I took from this is that if there was to be a second wave, we probably will think carefully before we intubate people. We probably will stop and think about it a bit more than just rush in and intubate. I think we worry about oxygen delivery, but make sure we're not delivering too much and maybe reduce the oxygen consumption. And I certainly, throughout this crisis, have been monitoring brain function with the SEDline and O3 because I was concerned about oversedation, which is quite a significant proportion of these patients. And I was also concerned about oxygen delivery. And if I can't deliver enough oxygen, I wanted to make sure the consumption was reduced. So there's a lot to be taken from this. TNI is a great way of going forward. ORI gives us another dimension rather than just a pulse oximeter, and certainly measuring brain function and oxygenation really is the ultimate, because it is the ultimate end organ that we want to protect. So again, I thank you all for your time and contribution. Thank you, Chiara, for co-chairing this with me, and thanks to the European Society of Intensive Care Medicine and Massimo for sponsoring this. Thank you again, and hopefully we won't get a second wave.
Yes.
Thank you so much.
Finger crossed.
Thank you. Bye-bye now.
Bye-bye. Thank you.
Bye.